Good evening, everybody. Welcome to the next sessions of the ATS COVID-19 Critical Care Training Forum. It's been a while since we've all been together. Welcome back. I wish, in my heart of hearts, I wish that we weren't back together having another COVID-19 Critical Care Training Forum. But given the environment and the Delta variant and the surge that we're in, I think it is important that we all are together to talk about what's going on and to get this topic, which is updates on COVID treatments from the front line. So welcome, my name is Nirav Shah. I'm thankful that all of you took time out tonight to join us. So tonight, your moderators are myself, Nirav Shah from the University of Maryland, and Dr. Isabel Pedraza from Cedars Sinai, the director of the Medical Intensive Care Unit at Cedars Sinai. Our case presentations are going to be by two fellows, David Kaltman from the University of Maryland and Eric, please forgive me if I say your last name incorrectly, Mlodzinski from the University of California, San Diego. And our faculty presentations, we're privileged today to have Dr. Andi Levine from the University of Maryland and Dr. Bob Owens from UCSD as well. Upcoming sessions on September 7th, Drs. Varen Kaul and Isabel Pedraza are going to host the COVID-19 vaccine boosters and future of COVID-19 vaccination session. Episode 35 is going to be hosted by Dr. Sushma Cribbs. It's Caring for Yourself So You Can Care for Others, How to Manage Anger, Frustration, and Sadness in the Setting of Caring for Unvaccinated Critical Care COVID Patients. And then a topic that I really wish that we didn't have to have a session on, but I think with the Delta variant we're seeing more and more of, is episode 36 on October 5th, COVID-19 in children. These topics are conversations that have been generated by viewers, by people that have asked for these topics. And if any of you have topics that you're interested in, please definitely include that on the evaluations and surveys. There are additional sessions. These were recorded and are available free on the ATS website. Over 30 different sessions that are there for the critical care COVID-19 training forum. And I think that you'll find some really interesting things and still timely as well. I know for us at Maryland, we've definitely seen some obstetrics and COVID-19 in the ICU in this latest surge as well. So 32 CCCTF episodes all posted on the website. You can search for ATS COVID Forum or scan this QR code that's on your screen. In addition, we need your feedback. We like to tailor this to the feedback that we get from all of you. And so here's the QR code for feedback, and we'll pop this up again, and put a link in the chat box as well. But please provide us with your feedback. Your ATS COVID-19 Critical Care Training Forum chairs are Dr. Laura Crotty-Alexander from UCSD, myself from the University of Maryland, Dr. Sushma Cribbs, and Dr. Varen Kaul. All have kind of worked together to put these sessions together, along with a team of trainees, Alex Cipro, Cameron McGuire, Ali Ashgar, Neil Jones, and Mark Wolfson. And then our ATS staff, who we couldn't do this without, Ms. Lauren Lynch, Ms. Liz Guzman, Ms. Eileen Larson, and Ms. Allison Corey. So I'd like to thank all of them for their hard work in bringing this forum to you. And so with that, I'm going to stop sharing my slide set, and we're going to go to Dr. David Kaltman from the University of Maryland, who's going to start us off with a case. Thank you, David.
Perfect. All right. Thanks, everyone. My name is David Kaltman. I'm one of the critical care fellows from Maryland, and I'll be getting us started with a case presentation to kick off our discussion about updates in COVID-19 treatments. So the case begins with a 37-year-old woman with no significant medical history who presents the emergency department with 4 days of shortness of breath and fatigue. She actually completed a COVID mRNA vaccine series already in June, though she recently traveled to Florida. And her only other medical history is notable for the fact that she takes prescription oral contraceptive pills. On further history, the patient actually tells you that she took a home COVID antigen test already earlier today, and it was positive, which led her to try to seek out monoclonal antibody therapy, but she did not have a prescription for this. So she has come to the emergency department today asking for monoclonal antibody treatment. Her triage vitals show that she is febrile, a little bit tachycardic. Her blood pressure is okay. She's borderline tachypnic. Her pain score, just kidding. The actual fifth vital sign, her oxygen saturation is 87%, which then improves to 94% on 4 liters nasal cannula. On physical exam, the patient does have mildly increased work of breathing and is noted to have coarse breath sounds, but no peripheral edema. And the balance of the physical exam is fairly unremarkable. So I think you know where this is going, given that this is a COVID-19 lecture series. So she has a rapid antigen test for COVID that is indeed positive, confirming the one that she had already taken at home. And she gets additional laboratory testing in the emergency department, CBC and a chem panel, which are within normal limits. She gets some inflammatory markers, including a D-dimer and CRP, which are moderately elevated, and she is not pregnant. Given the elevated D-dimer and the fact that the patient was on oral contraceptive pills, the ED team decides to order a CTA of the chest, which does not demonstrate any pulmonary embolism, but is notable for the typical multifocal ground glass opacities, very characteristic of COVID-19 pneumonia. So she is given 6 milligrams of oral dexamethasone in the ED and then admitted to the medical service. And the admitting team then additionally orders these following 3 medications, which are remdesivir 200 milligrams once, and then 100 milligrams daily for the duration of a 5-day course, baricitinib 4 milligrams daily, and then enoxaparin 40 milligrams sub-Q daily, which is the standard prophylactic dose anticoagulation in our institution. So she's admitted to the hospital, and unfortunately, as we've seen many times over the subsequent on hospital day 4. However, fortunately, and all of her previously ordered medications are continued. Fortunately for her, she actually is successfully extubated by hospital day 9, and then, in fact, discharged to home about 2 weeks after being admitted to the hospital. Amazingly, she's not given any prescriptions on discharge from the hospital, which I feel like is certainly a rare occurrence. And she is advised to actually hold her oral contraceptive pills until outpatient follow-up with her primary doctor, given the concerns about the hypercoagulable state in the kind of early post-COVID infectious period. And that's all I got. Thanks very much for your time.
All right, we'll go on to Dr. Andi Levine, who is going to take us away with her conversation about a more precise approach to pharmacotherapeutics for patients with COVID-19.
Thank you, Dr. Shah and Dr. Kaltman. Very nice case to introduce us into the next topic we're going to go into today. So as Dr. Shah said, this is going to be about a precise approach to treating patients with COVID-19. And so I want to start with the take-home message. So if you don't remember anything else, this is what you remember, which is that it's important to pick the right drug for the right patient at the right time. And hopefully by the end of this, you will better understand which patient that is. So this is a picture of President Barack Obama. This is at his State of the Union address, and this is the DNA double helix next to him. And this is when he's really starting to introduce the precision medicine initiative. And this may not be exactly what we think of when we think of precision medicine. We often think of people's genotypes and their underlying genetic makeup, and we think about their microbiome, and we think about designing interventions that really target those variations in patients. But I want to implore you today to really think about the particular patient that you're treating in front of you, and at what point in the disease process you're treating this patient, and what that patient looks like, and really pick the intervention, pick the pharmacotherapeutic intervention that fits best with where that patient is. And hopefully you'll have a better understanding of that by the end of my talk. This is a really nice infographic that I borrowed from a friend and colleague of mine, Dr. George Kitsios. And again, this is kind of walking through the viral phase of COVID-19 and then the inflammatory phase of COVID-19. And you'll see as we walk through this talk that really timing is sort of everything, and that it's critically important that, again, you think about where your patients are on this infographic. Are they in this highly replicating viral phase, or in this profound inflammatory phase? So again, I want to walk through this a little bit historically. This is the way the drugs kind of came out and the way that we were seeing them as clinicians. And I'm also going to use this PCOTS or PCOTS template to walk through all of these papers. Each of these papers could in and of itself be a talk, so I'm going to kind of just hit the highlights on each of them. So remdesivir was really the first pharmacotherapeutic intervention we had for patients with COVID-19. This is coming from the ACT-1 study. And so this focused on hospitalized patients with COVID. The intervention was remdesivir, 200 milligrams as a loading dose, followed by 100 milligrams daily through day 10 or through hospital discharge, whichever came first. The comparator was a placebo, and they were looking, which you'll hear a lot about during this talk, and has become kind of a convention for an outcome that we look at in these COVID trials. They were looking particularly at the 28-day time point, and this was a double-blinded, one-to-one randomized placebo-controlled trial. Really just to show you kind of the main finding of the study is that patients who were treated with remdesivir recovered earlier and were more likely to recover than patients who were treated with placebo. And this was a large study. So this was over 1,000 patients, as I said, one-to-one randomized, so about 500 patients in each arm. And so there was obviously an improvement in the rate at which these patients recovered. They found this to be mostly in severe disease, which is not necessarily how I would define severe disease, but these were patients who were mechanically ventilated on supplemental oxygen or patients who were found to be hypoxic at room air. And they really, within that group, found that the biggest impact of remdesivir came in patients who had this baseline ordinal scale of 5. And that's patients who are hospitalized requiring oxygen. They had the biggest impact from remdesivir. In contrast, the patients who didn't get quite as much impact were the patients who were mechanically ventilated or on ECMO. They really had no benefit at all from the drug. So overall, we sort of had this micro population that we can target, which is this in the hospital on oxygen, but not the most critically sick. And so in terms of our precision medicine approach, what's the population? Again, patients admitted to the hospital requiring some oxygen, but not the sickest of the sick. And then when should we use this drug? Probably slightly earlier on in the disease process based on the way the drug works. And so that was the first drug we had. The IDSA is currently recommending that the use of remdesivir is in hospitalized COVID-19 patients. The NIH is recommending that patients who are hospitalized and on supplemental oxygen, but they add this caveat of minimal oxygen support, although don't further define that. And then the SCCM is suggesting against remdesivir in the use of patients who require invasive mechanical ventilation, but otherwise recommend the use of remdesivir. So all the guidelines are pretty much in alignment, and I think we have a better sense now of when to use remdesivir. And so back on this infographic, I would put remdesivir sort of here at the tail end of the viral phase, patients who are in the hospital requiring some oxygen, but certainly not our most critically ill ICU patients. So is there more to come on remdesivir, or have we kind of heard all about it? This is some work that actually was done by a friend and former colleague of mine, Kat Paulus, and she really looked at, was the ordinal scale the best outcome to look at? And the punchline is no, that perhaps the ordinal scale should be combined with other biomarkers, which we'll hear more about today, but things like ALC and ANC, and perhaps those labs in combination with the ordinal scale are really more important to look at and collectively could actually predict which patients are going to have worse outcomes from remdesivir. So maybe there's more to do in the work with remdesivir, and that if we combined our ordinal scales with the biomarkers, we would actually better be able to address who exactly would benefit from treatment with remdesivir. So next came dexamethasone, and this came from the first platform of the recovery trial, which is an adaptive platform trial. This was in hospitalized patients with COVID-19. They got dexamethasone 10 milligrams a day. This was compared to standard of care. There was no placebo. They looked at all-cause mortality within 28 days after randomization. And this was a double-blind, 2-to-1 randomized, open-label control trial. In this study, about 2,000 patients received dexamethasone, 4,000 patients received the standard of care. And this is, again, the money shot from the recovery trial. So if you look at all the participants here in the upper left, panel A, if you compare usual care to dexamethasone, there was a reduction in mortality with dexamethasone administration, and that was a rate ratio of 0.83. But this was really even more striking if you looked within the substratifications or the subgroups that were based on oxygen utilization. And so if you look at patients who required oxygen only, again, there was a reduction in mortality with dexamethasone, but it was the most striking in patients who were requiring invasive mechanical ventilation. And in this subgroup, we saw that there was a rate ratio of 0.64. So a 40% reduction basically in mortality in patients who received dexamethasone. And this was astounding. It was after this that we really started to utilize dexamethasone in our critically ill patients. And then just a forest plot kind of echoing the same sentiments that I just said. In our invasive mechanical ventilation patients, we saw the greatest benefit for the use of dexamethasone, specifically with the outcome of mortality. Still benefit in patients who got oxygen only, although to a lesser degree, and actually a trend towards harm in patients who were not on any oxygen who got dexamethasone. Overall, without the substratification or the subgroups, there was a benefit of dexamethasone, but again, mostly in our invasive mechanical ventilation patients. I do want to say that there was really no additional details on what oxygen only meant. So were these nasal cannula, were these high flow nasal cannula, how much oxygen were they on? That was really unclear from the recovery trial, but certainly it was clear in these critically ill patients that there was a benefit. So when I think about the precision medicine here, I think that this really benefits patients who require invasive mechanical ventilation, patients who are on ECMO, patients who are on oxygen, but question mark how much, we don't really know. And so perhaps it's slightly later in the disease process when we enter into this hyperinflammatory process that we know contributes to ARDS. If you look at the current guidelines, the IDSA is recommending the general use of dexamethasone in hospitalized patients with critical illness and severe disease, but not in hospitalized patients without severe or critical disease. And they also use a little bit of a different definition for both severe and critical illness. So the patients who have severe disease are patients who are hospitalized and who require oxygen. The patients who have critical illness are the typical sort of ICU patients on high flow nasal cannula or invasive mechanical ventilation or ECMO. And the NIH recommends against dexamethasone in non-hospitalized patients or patients not on any oxygen, but recommends it in all other patients. And the SCCM recommends dexamethasone for severe or critically ill COVID-19 patients. So again, seeing it in a little bit of the sicker patient population. And so now on this infographic, you're going to see here corticosteroids, I think, fall as we enter into this inflammatory phase, right? The viral phase is at the tail end, the inflammatory phase is revving up. These are sicker patients, certainly requiring oxygen, but definitely also getting into the ICU kind of patients. So is there more to come here? We heard all of it. Well, a recent preprint of the COVID steroid 2 trials come out, and that shows a trial looking at 6 milligrams versus 12 milligrams of dexamethasone. There was a trend towards improvement with 12 milligrams, but not significant. So I caution you about kind of trends that are not significant. But when they looked at the overall outcomes, there were certainly no worse outcomes with 12 milligrams of dexamethasone. So perhaps in another trial, a larger patient population, we'll see that actually 12 milligrams may be better. And there's a lot of research coming out now looking at dexamethasone versus methylprednisolone, arguing that perhaps the concentration in the lung tissue is higher with methylprednisolone. And so there's both randomized control trials and also lots of retrospective analyses looking at this. So I think more will also come out in time about the comparison between these two types of corticosteroids. Dr. Kaltman had mentioned the patient in his vignette received baricitinib. So baricitinib was initially studied in the ACT-2 trial. Again, this was the same adaptive platform trial where remdesivir was initially studied. Because remdesivir had now become standard of care, this was baricitinib plus remdesivir. These were, again, the same patients hospitalized with COVID-19. The intervention was baricitinib on a backbone of remdesivir. The comparator was a placebo, again, on the same backbone of remdesivir, which was standard of care. The outcome of interest was time to recovery on the 8-point ordinal scale. So again, should sound very familiar. And they were looking primarily at a 28-day endpoint. The Kaplan-Meier curves from the baricitinib plus remdesivir looks like the patients who were treated with baricitinib were more likely to recover and also recovered earlier on than patients who did not receive baricitinib and received remdesivir alone. And this was the most striking in this ordinal scale of 6. So these are the high flow nasal cannula patients, the non-invasive mechanical ventilation patients. These are not the patients in our ICU. These are not the patients that are on ECMO necessarily, but these are sort of the IMC or just entering into the ICU kind of patients. And they got the most benefit in terms of days to recovery and the likelihood of recovery. More recently, baricitinib has been studied with dexamethasone, and this is also from a preprint. This is the COVE barrier study, again, not yet in formal print or peer review. These are hospitalized patients who have COVID-19. They're looking at baricitinib, 4 milligrams a day for 14 days plus standard of care, comparing it to placebo plus standard of care. These are patients who are pretty much all on corticosteroids. So dexamethasone wasn't part of the intervention, but it's part of the standard of care here because we're so far along in the pandemic. They're looking at the outcome of progressing to high flow nasal cannula, non-invasive or invasive mechanical ventilation or death at a 28-day time point. This is a double-blinded 1-to-1 randomized placebo-controlled trial. In this study, it looks like there was no difference in this progression at day 28, whether you're on baricitinib or not. But the finding was really that there was a significant improvement in 28-day all-cause mortality with a significant reduction in the hazard ratio of mortality to be 0.57 in patients who received baricitinib. This was the most pronounced in the subpopulation who were on oxygen and actually not on corticosteroids, so the very small number of people who did not get corticosteroids in this trial. And the hazard ratio there was 0.31, so pretty striking. And so then when you look at the forest plot here, you see a benefit again. These are the ordinal scale patients of 6, so these are sort of the high flow nasal cannula, non-invasive patients. They got the greatest benefit in terms of 28-day mortality. This was beneficial to patients both on and off of steroids, but more beneficial to patients who were off of corticosteroids. Beneficial primarily to patients not on remdesivir, interestingly, although the initial, like I said, Act 2 study was really in patients on a backbone of remdesivir. And then interestingly, this drug was found to be beneficial both in those early on and later on in the disease process, both before and after 7 days. So in terms of our precision medicine, what patient population should we use this drug in? I think the patients requiring non-invasive or high flow nasal cannula based on both the Act 2 and the preprint, at least, of the baricitinib plus dexamethasone study. I think we can really use it anytime during the disease process. So meaning if your patients have had symptoms for more than a week or so, you can still use it. And I do think we should use it in combination. So remdesivir and dexamethasone, or sort of all three as a drug combination is probably the best bet, given that's how we've studied it, is really always with a backbone of either remdesivir or with steroids. The current guidelines from the IDSA are recommending using it with remdesivir or remdesivir with steroids in hospitalized patients with severe but not critically ill disease. So again, on oxygen, on high flow, but not ECMO, not invasive mechanical ventilation. The NIH is saying the use of baricitinib in patients recently hospitalized with rapidly increasing oxygen requirements, and use it in combination with both dexamethasone and remdesivir. And the SCCM really doesn't mention it in their guidelines. Here on our infographic, I put baricitinib up here. So again, sort of earlier on in this inflammatory phase, these patients who are sick, but not the sickest of the sick, and really in combination with corticosteroids and remdesivir. So is there more to come on baricitinib? I think so, right? So we really haven't looked at the combination of baricitinib and tocilizumab. Not sure that's ever going to happen. We haven't really studied them on a back-to-back or a head-to-head comparison. And so really the IDSA specifically says they can't make any recommendations between the two drugs because they've never been studied head-to-head. All right, so tocilizumab. So I'm going to specifically talk about the REMAP-CAP study for tocilizumab. I think it's the best designed study. I think it's the most well executed of the studies. Most of the TOSI studies have been negative to date, with the exception of the recovery tocilizumab study and then the REMAP-CAP study. So the REMAP-CAP study is, again, an adaptive platform study looking particularly at patients who are critically ill with COVID-19. And this study looks specifically at patients admitted to an ICU requiring high flow, non-invasive or invasive mechanical ventilation, or cardiovascular support like pressors or inotropes. And they have to be enrolled very quickly, so within 24 hours of starting organ support. It's a very narrow enrollment window. It's a very specific patient population. The intervention is tocilizumab, a single dose with a possible additional dose to be repeated. And then I'm going to mention sarilumab just very briefly so we can talk about that in a few slides. That was an additional arm in this study. This is being compared to standard of care. There's no placebo. The primary outcome is number of respiratory or cardiovascular support free days at the 21-day endpoint. And this is a randomized controlled study. So what you see here is that in patients who got tocilizumab, there's more organ support free days. So these blue days are organ support free days. So there's more organ support free days when you compare tocilizumab to the control. And they added sarilumab in here. Like I said, there was only about 45 or 48 patients who were on sarilumab in this particular study. Sarilumab looks like it was at least as good as tocilizumab in terms of reducing the organ support free days. And so again, compared to the control, at least, it looks like these drugs are effective in terms of reducing organ support free days. I think this is critically important. So this forest plot is coming from the recovery study, so a different study. But mostly what I wanted to point out here is that the benefit of tocilizumab, the only benefit we've ever seen of tocilizumab, is in combination with corticosteroids. Actually, every other tocilizumab study, for the most part, has been negative, showing no benefit and sometimes even harm. But when we use tocilizumab in a backbone of people who were all on corticosteroids, there was a benefit here. In patients not on corticosteroids, there really is no benefit and maybe even a trend towards harm. In the REMAP-CAP study, again, because of the timing in the pandemic, almost all the patients were on corticosteroids. So with TOSI, it's important to use with corticosteroids. So what patient population? I think the critically ill patients, I think specifically to be used within 24 to 48 hours of ICU admission. I think the patients who come to your ICU after being somewhere else for a week, 2 weeks already, not getting better, this is probably not going to help them. I think it's critically important that you use this in combination with dexamethasone. It has not been proven to be effective on its own without dexamethasone. The IDSA is suggesting that we use this drug in severely ill patients and in critically ill patients. So again, like the high flows, the non-invasives, and then of course our invasive ventilation and our ECMO patients. The NIH is recommending it with dexamethasone in hospitalized patients who have rapid clinical decline, which I defined here. And then the SCCM really isn't mentioning tocilizumab, at least in their guidelines when I checked earlier this week. So I would put tocilizumab here on this infographic a little bit later into the inflammatory phase as the patients are entering into the ICU, not when they're late in their ICU course, but really early on in the ICU, really targeting this hyperinflammatory phase and to be used with dexamethasone. So is there more to come on toci? Well, I already alluded to this. There has not been a head-to-head comparison of toci versus baricitinib. I think the one thing I just do want to mention is about sarilumab. So in the initial REMAP CAP study, there was only about 50 patients who got sarilumab, but there was an obvious trend towards benefit. There's now a REMAP CAP preprint that's coming out. I suspect it will be published imminently. They have more than 400 patients at this point who've gotten sarilumab. They're looking at the same outcomes of organ support free days, hospital survival, ICU, and hospital discharge. All are significantly improved with the use of sarilumab compared to control. It looks like sarilumab is at least as good as tocilizumab. And I think that that's important because, as many of you may be experiencing, there's actually a nationwide shortage right now of tocilizumab. And as you may know, we use tocilizumab for other kinds of patients like CAR T patients. So there's actually a need to hold on to this drug for some of these patients. And so if we have an alternative therapy like sarilumab, we may have an equally good therapeutic intervention for these patients. Just super quickly, I want to just mention convalescent plasma. Really, there's never been any studies to support the use of this. We've looked at high titer and low titer convalescent plasma. Really no evidence to support it. So all these institutions have basically said no recommendation for the use of convalescent plasma. And then for monoclonal antibodies, as Dr. Kaltman had mentioned, there's some role for the use of monoclonal antibodies after exposure. But once you're looking at patients who are hospitalized or who have severe disease, really no role, no recommendation for monoclonal antibodies. SCCM kind of pleads the fifth on this and doesn't make a statement, but everyone else says against the monoclonals. So most important thing, again, if you tuned out for the whole presentation, pick the right drug for the right patient at the right time. Do some thinking about that. This is critically important for us to actually treat and get our patients better. This was just an infographic that came out of the New England Journal of Medicine, kind of using these ordinal scales to remind us of when these drugs were most appropriately used. I added tocilizumab to it, but we already kind of went through all of this. And then again, just to thank Dr. Kitsios for lending me this figure. I put all of the interventions we talked about today, or he has on this figure, looking at, again, the timing and how it fits in with the viral phase and the inflammatory phase, where patients are as an outpatient or an inpatient, and just being really precise in the drugs that you choose and thinking about the timing of the drug and how they fit with where the patient is in their disease course. And I think that's it.
Thank you so much, Dr. Levine. This is Dr. Pedraza. I just took over for Dr. Shah. There are some questions posted in the chat box if you can get to them when you get a moment. I want to go on to our next case. Dr. Eric Mlodzinski who's a fellow at University of California, San Diego, will present our second case.
All right. Hey, everyone. How's it going? I'm Eric, one of the second-year fellows at UCSD in pulmonary critical care. So I will just start with the case, lead up to the discussion. So this was a 35-year-old with morbid obesity who presented last month with a week of shortness of breath and cough, and actually came to the ED for altered mental status. Was found to be COVID positive. And of note, he was vaccinated with 2 doses in January. So he was saturating 40% in the field. On arrival to the hospital, he's placed on high flow nasal cannula without much improvement to his sats in the 80s, switched to BiPAP, but was still saturating in the 80s, so was emergently intubated. Labs that were notable, his D-dimer was up to 1600, his troponin was elevated at 128, CPK was elevated, he had a leukocytosis as well. His initial ABG on 100% FiO2 post-intubation, 745, 45, and 53, leaving with a P to F of 53. This was his chest X-ray pre-intubation, so kind of diffuse disease consistent with COVID pneumonia. He was placed on high PEEP settings at 20, still saturating in the 80s, so he was paralyzed and started on inhaled nitrous oxide. And despite this, was still persistently hypoxemic, so was then proned with some mild improvement, but still with a P to F of 96 despite all of these interventions. So the decision was made to cannulate for VV ECMO in hospital day 2, and he did have improvement. And I think I may have forgotten to mention with all this, he was initially started on a heparin drip for due to the elevated D-dimer. Started on remdesivir and dexamethasone. It was given Lasix for diuresis on arrival. He has unfortunately had a very prolonged and complicated hospital course, complicated by acute renal failure requiring CRRT. He's had bilateral pneumothoraces with bilateral chest tubes, probably multiple episodes of VAP with persistent shock. And he actually required the addition of a second oxygenator to his ECMO due to persistent hypoxemia. Is unfortunately still critically ill in the ICU, not doing very well. And that is the case.
Thank you so much, Eric. I'd like to now introduce Dr. Bob Owens. Bob is a specialist in pulmonary and critical care medicine at the University of California, San Diego. And he's going to talk about ARDS and biomarkers for ARDS.
Thank you very much. Can you hear my audio okay?
Yes, sounds perfect.
Great. So, so thanks very much. I appreciate Eric sharing the case. I thought it was useful for a couple reasons. Like the first case, these were both patients who were fully vaccinated and yet developed severe disease, needing to be placed in the ICU. Both patients had elevated D-dimers, which I'll talk about. And in this particular case, it's been difficult to know who would need to go onto ECMO. So I'm going to talk about biomarkers for ARDS. I think Dr. Levine had a lot more specific data. This is a little bit more philosophical discussion at first, and then show you some data as well. But when I think about biomarkers for ARDS, that was the topic I was asked to speak about. Honestly, I was like, well, I don't know what biomarkers we actually use for ARDS. I'm also not totally sure that I'm the right person to give this talk. I'll let you know how I got involved in this. But here's what I wanted to cover in the 15 minutes or so we have. I wanted to think more generally about what makes a good biomarker. And I wanted to think a little bit about ARDS. And obviously, it's a heterogeneous disorder. And we typically look at something like the P to F ratio, but are there other things that we need to consider as well? I'll spend most of the time talking about whether there are any useful biomarkers for ARDS. And we'll finish by talking about biomarkers in COVID pneumonia. And that's where we're going to get in. I saw something in the chat about anticoagulation and looking at patients with elevated D-dimers. So just thinking about biomarkers in general, I think that you can use biomarkers for diagnosis, prognosis, or the choice or impact of therapy. It's always been as a pulmonologist, I feel unhappy that we don't have a troponin of the lung. That's something that Taylor Thompson would always impress upon us, is that we don't have a troponin for the lung. Things have really changed. When I first started as an intern, my chief resident, this guy Sal Chilme, we would always have to lay out our EKGs, put them in timeline, label them with chest pain, pain-free, all this kind of stuff. Now, when I get a presentation about a rule-out MI, it's all about the troponin. Obviously, something like prognosis, you could use Ranson's criteria for pancreatitis. And then if you're thinking about choice or impact of therapy, if you have a biomarker like a specific genetic mutation, well, then there you go. That's how things have advanced. And we are not really there when we think about biomarkers in ARDS. But wouldn't it be great to have a fantastic ARDS biomarker, because it could help us make the diagnosis? We know that ARDS is a heterogeneous disorder. Maybe it would help us homogenize and really figure out what kind of ARDS we're dealing with. It would certainly help us with disease recognition. And I think one of the takeaways that I think about from the LungSafe study, and here's the editorial by John Laffey and others, is that we miss ARDS quite a bit. And not only do we miss mild ARDS, even some cases of severe ARDS people miss. In terms of prognosis, I've spent the last year and a half, as probably many others on the call have, thinking about who needs to be intubated and when, and unfortunately, who needs to go on to ECMO and when. And it would be great to have a sense of, some magic biomarker that would say, yes, this patient is not going to get better and they're going to need ECMO. Similarly, I would love a biomarker readout of, is the lung, am I pushing on the lung too hard? I would love sort of a biotrauma ometer that would let me know if the current vent settings are hurting the lung right now. Am I hurting the other organs in the body as well? So that's what I would look for in a good biomarker. And I think the problem is I don't think we're ever going to have a single biomarker that fully captures all of the things that are happening in ARDS. And I think that's partly because when we think about diagnosing and assessing the severity of ARDS, typically we use the P to F ratio. But that's just one measure of gas exchange. And you can clearly manipulate the P to F ratio, as all of us do, with PEEP, with inhaled nitric oxide, inhaled vasodilators. And I'm sure there are other ways to do it as well. Think about PF supine versus prone. So I think if you really wanted to capture all the features of ARDS, you would need to think about minute ventilation or measures of CO2 clearance or dead space. I think you would need a measure of lung compliance, perhaps radiographic involvement. And I think you'd also want to know something about biotrauma. How hard are we pushing on the lung, whether it's the driving pressure or power? But again, ARDS severity, trying to encapsulate that with P to F ratio, or as all the studies we just went through, saying, the patient's on this amount of oxygen versus ventilation, we all make different decisions about when to intubate versus trying different oxygen delivery systems. So having said all that maybe ARDS is really complicated and we don't have great biomarkers, what is out there? I think it's always useful if you just go to PubMed and you type in biomarkers for ARDS, here's what you see. Certainly there are hundreds of papers that purport to be biomarkers of ARDS. And the spike here in 2020, there were 300 some articles. So clearly people are publishing on ARDS biomarkers. I guess my question for the group, and you can respond, in the chat, is, what biomarkers are you actually using? And if you scroll down this list, you can see things, I don't have any favorites here, but you see galactin-3 as a prognostic biomarker in patients with COVID ARDS, neutrophil extracellular traps, or NETs. You can look at monocyte to lymphocyte ratio. I think there are all these things that are out there. And so there really are tons of biomarkers in ARDS, but how many of these do we actually use? And again, in the chat, I would love to know what people actually use in real time to make adjustments to their ventilator strategy, decisions for intubation, things like that. And I think, unfortunately, we really don't have true biomarkers that are affecting real-time management. Obviously, when we talk about biomarkers, it doesn't have to be just a blood test. So this study by Rich Calais and the folks at UCSF and the ARDSnet, looking at physiologic dead space fraction, and they found a difference between survivors and non-survivors. You can see the VDVT on the y-axis here. So again, a biomarker can mean different things. It doesn't have to be a blood test. But this biomarker, just like all the other ones I sort of very briefly mentioned, it can be hard to find clear separation. So it can be hard to make to change clinical practice. So having said all that by way of background, the reason I'm giving this talk today is because one of our junior faculty is Mazen Odish, who couldn't be here today. He's unfortunately, fortunately for him, he's on vacation, but Mazen is a med peds guy and then trained in adult critical care, and he's really taken an interest in ECMO. And so this is Mazen here on a mobile ECMO run. He's published about that, several other features of our ECMO experience here at University of California, San Diego. And working with Mazen, I think the questions that have come up is, who are the patients that need ECMO? So is there a way we could predict who really needs ECMO? And then the other thing that he asked me as a fellow is, well, how do you set the ventilator during ECMO? And I think there's this idea that you rest the lung, but how do you know if you're resting the lung, and sort of how low can you go with resting the lung? So do we have a readout of how beat up the lung is getting from our ventilator? And that led us to this paper by Stuber and colleagues looking at biomarkers as you adjust your ventilator. And so this is a 20-year-old study, but they looked at patients with ARDS on lung protective ventilation, and they measured a hodgepodge of cytokines. And you can see IL-6, TNF-alpha. And as soon as you switch from a lung protective strategy to a low PEEP, high tidal volume strategy, you can see that these cytokines jump up within about an hour. As you go from injurious ventilator settings back to lung protective settings, you can see that, again, there's a drop in cytokines. So you get the sense that there might be some of these cytokine markers which we could use to actually know what kind of biotrauma we're causing to the lung. And this is something we're doing in our ECMO patients as part of a study where we turn basically the ventilator off, try to do apneic oxygenation, just let the ECMO do everything, and we're trying to see what happens to biotrauma. So as you can kind of tell, I'm maybe certainly agnostic, maybe a little bit down on biomarkers for ARDS. I do want to highlight this work by Carolyn Calfee and some others that I'll mention, trying to look at ARDS phenotypes. And I think this approach has had the most, has the most interest to me based on the work they've done so far. And so, as I mentioned, this is Carolyn Calfee doing a cluster analysis, essentially, of reanalyzing some of the ARDS network studies. And by doing so, they found two classes of patients. They called them phenotype 1 and phenotype 2. And later, they've sort of talked about one being hypoinflammatory and another hyperinflammatory. I'm not going to go through this very much. On the x-axis are a wide range of variables that separated the two groups out. But what's interesting is that when you look at the different phenotypes, you can see how they look different. So the hyperinflammatory group has a lot of people who were on vasopressors and a lot of people who had sepsis as the inciting cause of ARDS. And if you're interested in this topic, I have to give a shout out to Pratik Sinha, who gave a talk on this at the Fellows Track Symposium, and will do a much better job. And really, this is his story to tell. And that's available at this link here. He and I just happened to be speaking at the Fellows Track Symposium at the same afternoon, one talk after the other. And it was really an enjoyable talk, and he can go through this story much better than I. But just to highlight a couple things, these phenotypes are pretty useful in terms of prognosis. So if you had your choice, you'd want to be hypoinflammatory. So in the low tidal volume ventilation ARMA cohort, or in the PEEP adjustment alveoli cohort, phenotype 1 had a lower mortality at 90 days. The other thing that's really interesting is these phenotypes separate out response to treatment. And so the hypoinflammatory group does better with low PEEP and does worse with high PEEP. So if you look at the mortality at 90 days, the hypoinflammatory group on a low PEEP strategy, 16% mortality, 24% in high PEEP. It's the exact opposite, though, in that hyperinflammatory group, where low PEEP is associated with higher mortality. Taking this even one step further, looking at the SAILS study, and what I want to draw your attention to is looking at this figure over here, where if you look at those who were hypoinflammatory, whether or not they got placebo or simvastatin, no difference in outcome. But if you were in that hyperinflammatory phenotype group, if you got placebo, you did worse than the patients who got simvastatin. So again, showing that you can actually look at phenotype and it might tell you something about response to treatment. So could be a useful biomarker. Now, unfortunately, this group has tried to say, what are the minimum number of things that we can look at? And if you choose a 3-variable model, you can get reasonable sensitivity and specificity to look at whether you're hypo or hyperinflammatory group. But the model includes things like IL-8, protein C, not things that we typically think about measuring necessarily in real time. Obviously, this work is going on, and they're trying to think about clinical markers. Again, that's Pratik's story to tell, so I'll let you see the link there. So thinking about useful biomarkers for ARDS, and then the corollary, I think there's been this debate, is COVID ARDS the same as regular ARDS? This is the study by Bain and colleagues. And this has been a debate. Corey Hardin and the Italian group have gone back and forth in the literature on this. But if you look at things like P to F ratio, minute ventilation compliance, COVID-19 ARDS seems similar to other causes, whether viral, bacterial, or cultural negative ARDS. And also UPMC folks here, I should mention. And, from a biomarker standpoint, and the authors broke out the biomarkers, whether they're early, sort of middle, and late, you can see that, there might be some early changes with IL-6, but otherwise the biomarkers don't look too different, at least in this modest sample size. So at least from a biomarker perspective, I do think COVID ARDS is the same as ARDS. And there are a couple other studies on the slide here that seem to back this up. So the last thing I wanted to talk about with biomarkers is really to talk about as a cautionary tale. I think that there's been quite a bit of practice variation when you think about people using things like D-dimer, CRP, and really doing practice based on what they consider to be abnormal lab values. And it reminds me a little bit of the ferritin story and HLH story, where we had a rash of people being diagnosed with HLH before people actually had good studies recognizing that ferritin can be very high in the ICU in liver failure patients, renal failure, anything that activates macrophages too. So right now we're seeing patients with high D-dimer, and the question is, should we anticoagulate them? And the underlying assumption is, doesn't D-dimer equal clot? I think we know from the first case that was presented from Maryland that the patient had a D-dimer of 8,000, yet their CTA was negative. Early on, this was a study that was published back in February, where there was a D-dimer-driven anticoagulation protocol that reduced mortality in intubated COVID-19 patients. You can see that this was a study of about 200 patients, and they had a protocol here, which was kind of interesting, right? Where if the D-dimer was low, they used prophylactic dosing. If the D-dimer was very high, then they went to therapeutic anticoagulation with sort of a medium dose, a Goldilocks dose in the middle there. And at least in this study, you can see the cumulative mortality about 45%, but huge separation between patients who were on and off protocol. Now, this study designed for a couple of reasons was not very robust, but I think we definitely want to have more studies on this. And so there are two studies that just came out in the last couple months that I wanted to go over briefly. The first was in the Lancet. It's the ACTION study. You can see that it was published on June 4th, about 600 patients. It's a study out of Brazil where they looked at therapeutic versus prophylactic anticoagulation for patients in the hospital, elevated D-dimer. Now, their elevated level of D-dimer was just greater than the upper limit of normal, which is not incredibly high, but at least even when they looked at their data in tertiles, the highest tertile of D-dimer didn't seem to have any difference in outcome. You can see the interpretation here is in patients hospitalized with COVID-19, elevated D-dimer in hospital therapeutic anticoagulation did not improve clinical outcomes, and there was increased bleeding. Similarly, just published a couple weeks ago, now in New England Journal, you can see a consortium of some of the same groups that were mentioned by Dr. Levine, but therapeutic anticoagulation with heparin in critically ill patients with COVID-19, slightly larger study. D-dimer level was a bit higher, but again, in critically ill patients with COVID-19, initial strategy of therapeutic dose anticoagulation did not result in greater probability of survival. There was a slight increased risk of bleeding, but not enough to make the conclusions. Now, interestingly, there was a companion article in non-critically ill patients where there may be some benefit. But, my takeaway is that for the patients that all of us are taking care of in this group, we should not be empirically anticoagulating patients for just an elevated D-dimer, and we should not be doing anticoagulation without a good reason to. Of course, we should be using prophylactic dosing. So my sort of takeaway when I think about biomarkers for ARDS is it would be great to have a biomarker of ARDS. I don't know that any one biomarker is going to be useful. I love the emerging data about phenotypes. In terms of anticoagulation and biomarkers, I think, again, abnormal lab values should not drive clinical practice. See also high ferritin not equaling HLH. And for now, I think the data suggests that for ICU patients, we should stick to standard prophylactic dosing unless we have a good indication. So thank you very much. I'll stop there.
Thank you so much, Dr. Owens, Dr. Levine, for two really great talks. I wanted to give everyone an opportunity to ask questions, and there have been a few posted here. One of the things that we did a lot at our institution at the beginning that I haven't seen a lot on was awake proning. What's your opinion of the evidence out there, and do you guys use it at your institutions?
I'll just chime in. I think I feel like there has been, even in the last couple of days, good data to suggest that awake proning can help stave off intubation. I don't see personally any downside to doing it. I think it's one of those things like real proning in the ICU that there's not that much harm, so why not do it? The only thing I would say is that getting patients to prone is actually a little bit harder than I would like. And so as much as I advocate for people to prone and I talk to them about it, I feel like I'm probably not getting a whole lot of hours on their stomach, and there's a lot of kind of side and partial proning going on. But yes, I can't quote it off the top of my head. Maybe Dr. Levine knows, but yeah, it does seem like there's some good data in the last couple of days that we should be doing that.
Yeah, I think the paper was in maybe Lancet Respiratory Medicine, and I agree it was this week, and it looked at the outcomes of treatment failure, so looking at who had to be intubated, and it looked like awake proning was effective at kind of preventing the more invasive treatments that we need, like intubation in these patients. So I think if you can get your patient to do it, if they can do it otherwise safely, if your nurses are comfortable with it, I absolutely agree with awake proning.
There was also a question on whether the remdesivir, the data, although it does show some benefit, whether the benefit seen is really worth the cost. It is still a pretty expensive drug for most health systems. What are your opinions? I mean, in terms of, should we be spending this much, or should we be dedicating as much resources to remdesivir?
Go ahead.
Yeah,
please.
I guess I don't know the cost necessarily offhand. I know I was on a discussion today at the hospital level looking at the cost of medications and comparing Toci, baricitinib, and surilimab, and those drugs are costing anywhere between $1,000 and $3,000 for a course. Some of those courses are a single treatment. Some of them are multiple days of treatment. I think it depends. If you use remdesivir and you're able to stave off a patient ending up in the ICU, ending up on mechanical ventilation, those are very precious resources during a pandemic. Maybe not in some of our hospital systems now, but if you look at Florida or Texas, those are resources that they can't afford not to spare, and so whatever the cost of the drug is, if you can get a patient out of the ICU faster or keep them from being in an ICU bed, that's critically important. And so I think that we have to look beyond just the actual monetary cost and think about what the cost is of the entire hospitalization, what's the cost of being on ECMO, what's the cost of being intubated, but also the precious resources that we simply can't create. We can't create more ICU beds or ICU nurses. And so if we can spare those things, I think that's incredibly important.
Yeah, I agree. I feel like in our experience, it really has been a little bit disappointing in terms of the efficacy that we've seen. Another question was on steroids, and this is something that I've sort of struggled with. I'm interested to see what the results of the dexamethasone versus methylprednisolone study shows, because there's all these camps that use varying doses of each. I guess my question is, I know methylprednisolone is supposed to have more tissue deposition, but dexamethasone is more anti-inflammatory or has more anti-inflammatory potential. And also, should we be weight adjusting? I mean, is somebody who's morbidly obese, should they be getting the same dose that somebody who is not? Because that's something I struggle with. And do I really go up on the dose or not in these morbidly obese patients? And actually, in addition to that, should we be treating them for longer than we are?
I think the only other thing you maybe could bring up, I've heard people talk about sort of whether or not the drugs have mineralocorticoid activity and whether you're changing fluid balance on these folks. I think this is more of a philosophical thing, whether you're an evidence-based medicine person or you like to practice the art of medicine. And so, I typically am sticking with kind of what's been studied. I don't give my colleagues a hard time if they have someone with a BMI of 45 or whatever it is, or weight-based, and they want to go higher. But it's all, I don't think at this moment, I don't think we know the answer to those questions.
Yeah, I think I agree. There are questions because I think the Velar study that came out just prior to COVID was using a much higher dose of dexamethasone at 20 milligrams for 5 days and then 10 milligrams for 5 days. I think we've certainly used that dosing in some of our patients who are critically ill and not really responding to the 6 milligrams recovery dose. The Codex trial, I think, looked at higher dosing of dexamethasone also. Like I said, this COVID steroid 2 trial was looking at higher doses of dexamethasone. It doesn't appear that there's a harm. The patients aren't getting more secondary infection. So I think you certainly could escalate your dose of dexamethasone if the patient wasn't responding. I think also what we've seen a lot of is patients who get transferred to our hospital and require ECMO. So they've been at some other institution, they've been on recovery dose steroids. They're still obviously failing, their compliance is terrible. They get cannulated for ECMO. Those patients almost always get converted to Moderator protocol methylprednisolone, which is a weight-based dosing and also ideal body weight-based dosing, but also is a continuous infusion of methylprednisolone in the way the protocol is actually written, as opposed to sort of boluses of steroids. And anecdotally, those patients, if you ask our ECMO team, do pretty well. Their compliance seems to improve some. But yeah, I think there's a small study out of Iran looking at prospectively methylpred. The patients did better than the dexamethasone patients, and a couple retrospective analyses looking at methylprednisolone, and those patients overall did better. I think there's an ongoing RCT looking at the two, so I'm hoping to have some actually good answers soon.
I know that we are running out of time, so I want to ask, there's a couple more questions here. One is there a role for transfusion plasma exchange in severe COVID?
Not that I know of.
Yeah, I guess in addition, we really stopped using things like convalescent plasma a while ago at our institution because the trial results had been so disappointing. There's also a question on colchicine. I think Dr. Levine answered it in the chat, but on trials looking at colchicine in, is this in hospitalized patients or in outpatients that is being looked at? I've only seen it used in the outpatient setting, but I don't know if either of you are aware of trials looking at it on the inpatient setting.
I think this combat COVID trial is like moderate to severe patients. They're inpatient, but they're not the true sort of NICU ICU patient we might all be taking care of.
Okay. And let me see, I think there is one more question. Before tocilizumab, how many doses of dexamethasone should be given?
I think just concomitant. I don't think it's that you need to have dexamethasone at any specific loading dose or anything like that. I just think that the efficacy of tocilizumab is not present without the use of dexamethasone. I personally believe TOCI should really target those patients very early on in their critical illness. So those first kind of 24, 48, maybe 72 hours. So you certainly don't want to wait until they've completed their 10 days of steroids. But if I give one, I'm giving both.
And I actually have a question. Do you use a cutoff, a CRP level cutoff to give it? Or if they're critically ill enough, you assume that it will probably be elevated and it's to try and stave off intubation? these levels take a while to come back, and so I never know whether it's worth waiting for or not.
I don't, and I also think that different institutions have different levels based on, are they, decigrams per liter or whatever. And so I think they can be confusing to the clinician to interpret. And I think, like you said, they may take some time to come back. We know TOSI is going to bring your CRP level down, but we want it to do is to sort of stave off your decompensation. And so I wouldn't wait for that biomarker to come back. I don't think it's super meaningful. Some of the guidelines recommend essentially if your CRP level climbs by X or gets above 75 to use TOSI, but I really just think targeting that super early critical care period is important. And so if you have to wait based on your biomarker, you may miss your window.
Yeah, and I think the point of both your talks is that a lot of these therapies are going to be effective very early on in disease, when patients are either presenting to the hospital or initially going to the ICU, and that getting these treatments on early is of paramount importance. And after that, it really, I think, is probably ARDS care, which we know how to do. I want to make sure there are no other questions. Oh, what are your current steroid dose at your daily practice? I think we are using dexamethasone at 6 milligrams. Like I said, at times we go up on the dose if it's somebody obese. I think that's the practice, or is your practice any different than that?
That's what we also do. I do want to just go back and say, particularly for your biomarker, that yes, that different institutions have different scales, different assays, and so it's very hard to translate these. And I would also say maybe Dr. Levine's the same, but we're a referral center and we are seeing people on getting all sorts of very strange therapies before they come to us. And so that may have modified my practice to say, let's stick with what we know. But they're still coming to us despite getting all sorts of crazy therapies. And I would really encourage people to stick within the guidelines for now.
Yes, and I think the outbreak of mucormycosis that was described in India was related to, among other things, these very largely varying doses of steroids, often multiple times what has been studied. So anyway, it's past the hour now, so I know it's pretty late on the East Coast. I want to thank everybody for attending, and I want to thank Dr. Levine and Dr. Owens for great talks, and thank the fellows for their case presentations. I wanted to remind everyone that the next webinar will be on September 7th, where we'll be discussing booster vaccines, vaccine efficacy, and how this infection will likely become, how does it become endemic? So please join us on September 7th. We'll be sending out an email sometime, I believe, next week. Thank you again for attending. Have a great evening.